failure. But before that, some of the key concepts related to heart failure. What are the factors that lead to heart failure? So these are some of the determinants of heart failure. The first one is increased heart rate. So when the heart rate increases, for example, in tachyarrhythmias, the workload on the heart increases, there is increased strain on the heart, and this can lead to heart failure. The second factor is increased preload. So preload is related to end diastolic volume. So when the end diastolic volume increases, the ventricular filling during the diastole increases, and this causes stretch on the myocyte, and this in turn increases the force of contraction, further increasing the workload on the heart in a failing heart. So this can also lead to heart failure, and this can happen in aortic insufficiency and mitral regurgitation, increasing the blood flow to the ventricles and increasing the end diastolic volume. The third factor is increased afterload. As we know that afterload is related to systemic vascular resistance. So when the resistance in the blood vessel increases, for example, in hypertension or atherosclerotic diseases where the peripheral vascular resistance increases, the heart has to work harder to overcome the resistance, and this increases the workload on the heart, increasing the risk for heart failure. Lastly, decreased contractility of the heart. This happens in myocardial infarction, coronary artery disease, cardiomyopathy when there is a defect in the cardiac myocyte, and this can decrease the contractility of the heart, decreasing the cardiac output, leading to a failing heart, leading to pump failure and heart failure. So these are some of the factors to lead to heart failure. So what is the therapeutic objective? As we can see that increased heart rate, increased preload, increased afterload leads to increased workload on the heart. So the therapeutic objective is to decrease the workload on the heart by decreasing the preload, by decreasing the afterload. Also by increasing the contractility of the heart. So by increasing the contractility, the cardiac output increases. This decreases the congestion, back pressure in the heart, and this helps to relieve the congestion in heart failure. Therefore, there are drugs such as inotropic agents that increase the contractility and improve the cardiac output. So which are the drugs that increase cardiac contractility? These are Digoxin, which is a cardiac glycoside. It has positive inotropic action. It increases the force of contraction, increasing the cardiac output. The stroke volume increases. The congestion decreases, and this helps in symptomatic control in heart failure. The second group includes phosphodiesterase inhibitors, and the drugs are ambrinon, milrinol. They act as inodilators, which means that they have positive inotropic action, and also they dilate the blood vessels, decreasing the end diastolic volume and decreasing the workload on the heart. The third group includes catecholamines, which includes epinephrine, norepinephrine, dopamine and dobutamine. So amongst these drugs, dobutamine is the preferred, it is the best inotropic action because it has a selective beta-1 agonist action. It stimulates the beta-1 receptors of the heart, increasing the force of contraction. It has a short half-life, rapid onset of action, and it is a stronger, it acts faster. And since it acts faster, it is preferred in acute heart failure or decompensated heart failure. So now the question is, why do doctors still prefer digoxin in chronic heart failure when dobutamine is stronger, faster? The answer lies in the mechanism of action, how these drugs work and who really benefits. So in this video, we will break down the science and explain why digoxin still wins in the long run. How does digoxin work as a positive inotropic agent, increasing the force of contraction, increasing the cardiac output, stroke volume increases, congestion decreases, and thereby helps in symptomatic control and heart failure. So this is the figure of a cardiac myocyte. During each cycle of membrane depolarization, sodium enters into the cell via the sodium channels and calcium enters into the cell via L-type calcium channels. So this increases the cytosolic calcium, and calcium binds to troponin C, and this activates the interaction between actin and myosin, causing contraction. Now during diastole, the excessive calcium is pumped back into the sarcoplasmic reticulum via SERCA2. So SERCA2 pumps or transports the calcium into the sarcoplasmic reticulum, and the remainder of the calcium is removed from the cardiac myocyte via two transporters. The first transporter is calcium ATPase pump, and the second one is the sodium calcium exchanger, which removes calcium from the cardiac myocyte, from the cardiac cell. Now to be noted that the gradient for sodium is maintained by the sodium potassium ATPase pump, which extrudes sodium out and helps in the entry of potassium. So this maintains a gradient across the sarcolemmal membrane, and this gradient is also linked to the functioning of the sodium calcium exchange transporter, which is responsible for the removal of calcium from the cardiac cell. Now when digoxin is administered, it inactivates the sodium potassium ATPase pump. So when the sodium potassium ATPase pump is inhibited, this also inactivates the sodium calcium exchange transporter, which is responsible for the removal of calcium. So sodium calcium exchange transporter is inactivated, so the calcium that is removed by this transporter is inhibited. Calcium accumulates inside the cell. There is increased calcium inside the cardiac myocyte, and this increased calcium enters into the sarcoplasmic reticulum and is stored during diastole. Now during the next phase, during the next cycle of depolarization, when the depolarizing impulse reaches the cardiac myocyte, this extra calcium that is stored in the sarcoplasmic reticulum is released through the rhinodine receptor, and this increases the force of contraction. The contractility increases, the cardiac output increases. So in this way, digoxin acts as a positive inotropic agent. So now that we have discussed the mechanism of action of digoxin, let's now move on to the benefits of digoxin. The first one is the hemodynamic effects. Digoxin acts as a positive inotropic agent, increases the contractility, increases the cardiac output, and the ejection fraction increases. But here it is important to remember that unlike other inotropic agents such as catecholamines, digoxin increases the force of contraction, but the duration of systole is reduced. And since the duration of systole is reduced, the diastolic period increases. The time in which the ventricle spends in ventricular filling is increased. The relaxation of the heart is increased. This decreases the workload on the heart, and this is helpful for a failing heart. So digoxin, while increasing the cardiac output and ejection fraction, also decreases the workload on the heart by increasing the period of diastole, and therefore it is preferred in chronic stable heart failure. The second effect is neuromodulatory action. Digoxin also to some extent inhibits the sympathetic nervous system activity. It also inhibits the renin-angiotensin-aldosterone system activity. So it has neuromodulatory action, but it is also again important to remember that this action is less marked than ACE inhibitors and ARBs. So ACE inhibitors and ARBs have marked neuromodulatory action, and therefore they are widely used in the management of chronic stable heart failure. The third effect is vagomimetic action, that because of the vagomimetic action, digoxin lowers the heart rate. It decreases the conduction through the AV node and decreases the heart rate. So digoxin plays a very important role in decreasing the heart rate, and therefore this is preferred in heart failure with atrial fibrillation. So heart failure with atrial fibrillation, digoxin is the drug of choice because of its vagomimetic action. Lowering the heart rate helps in controlling the ventricular rate in atrial fibrillation. Also, digoxin decreases the heart failure hospitalization. Decreased rate of heart failure hospitalization because of digoxin. It is important to note that digoxin does not provide any mortality benefit. Now, mortality benefit is provided by two drugs, that is beta blockers and spironolactone or mineralocorticoid receptor antagonist, which increases the survival, reduces mortality. No mortality benefit with digoxin. However, it decreases the rate of hospitalization. Let's now discuss dobutamine. Dobutamine is a catecholamine like epinephrine, norepinephrine, dopamine, dobutamine. All of these belong to catecholamines. How do they act? They stimulate the beta-1 receptor of the heart, activating an enzyme known as adenylyl cyclase enzyme. Because of this enzyme activation, there is increased cyclic AMP concentration. And increased cyclic AMP concentration stimulates protein kinase A enzyme. And kinase enzyme is responsible for phosphorylation of substrates. And because of the phosphorylation of the ion channels, calcium channels, there is increased entry of calcium through the calcium channels, and this helps in raising the concentration of sarcoplasmic reticulum calcium. More calcium is released by the sarcoplasmic reticulum during depolarization, during contraction, and thereby this helps in increasing the force of contraction, increasing the cardiac output, and acting as a positive inotropic agent. So what are the effects? Dobutamine acts as a positive inotropic agent, increasing the force of contraction, cardiac output increases, ejection fraction increases like other catecholamines. So negligible or little effect on heart rate, little chronotropic action, and this is an advantage over other catecholamines such as epinephrine, which stimulates the beta-1 receptors, increasing the heart rate, and workload on the heart increases. So dobutamine has no effect on heart rate, and also it has no action on alpha receptors of the blood vessels. And alpha receptors are responsible for vasoconstriction, increased peripheral vascular resistance, and increased workload. So since dobutamine has no action on alpha receptors, no vasoconstriction, and this allows sufficient perfusion to various organs. This helps in the perfusion to various organs. So dobutamine has a positive inotropic action, but the advantage is that it has no effect on heart rate, no vasoconstriction. So the workload on the heart decreases, and this is helpful in a failing heart. So what are the other advantages of dobutamine? It has a rapid onset of action. And since it has a short half-life, it is given by IV infusion. So rapid action, faster action, stronger action, and increasing the cardiac output, decreasing the preload, decreasing the afterload, and therefore it is helpful in acute decompensated heart failure. It provides immediate symptomatic relief in decompensated heart failure because of its rapid action, stronger action, increase in the cardiac output, decrease in the workload, and therefore it is preferred in the management of acute heart failure. And since it has a powerful contractility action, there is high incidence of arrhythmias. So incidence of arrhythmias can be seen with dobutamine, and it is not used for long term. So for long term, what do we prefer? We prefer digoxin in chronic stable heart failure for long term. The reasons are as follows. It has a long half-life. It can be given orally or intravenously. Mild increase in cardiac output, not a drastic increase in cardiac output. Therefore, it is not suitable in decompensated heart failure. Secondly, it decreases hospitalization rate. So this is an advantage. It decreases the rate of hospitalization, provides symptomatic control, and also helps in rate control. Now this is an important differentiating factor. Digoxin reduces the heart rate because of its vagomimetic action, whereas dobutamine has no action on heart rate. So digoxin is preferred in heart failure with atrial fibrillation, helps in controlling the ventricular rate in atrial fibrillation. But a disadvantage that is associated with digoxin is that it has a narrow therapeutic index. Because of its narrow therapeutic index, there is increased risk of toxicity with digoxin. So these are some of the key comparison points between dobutamine and digoxin. Dobutamine is preferred in acute heart failure, in acute decompensated heart failure, while digoxin is still the drug of choice in chronic stable heart failure, and also it is the drug of choice in heart failure with atrial fibrillation. So with this, we come to the end of this topic. If you find my video useful, please like, share and subscribe. Thank you for watching.